Hello, good afternoon, and thank you for giving me the opportunity to present my research today. I am Juhye Choi, a doctoral candidate at the College of Nursing, Jeonnam National University. First, I would like to thank Professor Crimes for arranging this seminar. During my visit, Professor Crimes has helped me view this Chatbot project from a broader health informatics perspectives. I would also like to thank Professor Jae-young Kwon from the College of Nursing. And he has an ongoing research with my supervisor and helped me make this research visit possible. Thank you. Yeah, during this visit, I have learned that research can grow through discussion with people from different fields and backgrounds. So today, I hope this is not only a presentation of my work, but also a chance to exchange ideas and hear your thoughts. So let me begin my presentation. My main research interests are older adult and chronic disease and the use of digital health to support healthcare. Today, I will talk about a study titled is the Developing and Evaluating a Human-Centered Retrieval Augmented Generation Chatbot for older adults with multimorbidity. Imagine an older adult who has both hypertension and diabetes. One day at home, this person feels disease and has chest tightness. The main question is not only what is dizzy or what may cause chest tightness. The real question is what should I do now? So, should the person stay home and monitor the symptoms, or should they contact a clinician, or should they seek emergency care right away? For older adults, this decision can be difficult because the symptoms may be related to several chronic conditions, medications, or non-specific changes. A delay or a wrong decision may also create safety problems. So I make the chatbot was designed not only to explain health information, but also to support the next action in uncertain situation. Next, I will explain why I focus on older adults. In this study, I viewed the vulnerability as the result of two areas they can overlap. First is related to aging and healthcare access. This doesn't mean that all older adults have the same problems, but some may face transportation limits or limited caregiver support or changes in vision or hearing or different level of digital health experience. The second area is the clinical complexity of multimorbidity. People may take several medications, follow different recommendations, and experience symptoms such as dizziness, fatigue, or chest discomfort that are not easy to link to only one condition. The main point is that the access barriers and clinical complexity can occur at the same time and make health decisions more difficult. For this reason, I believe there was a need for timely, understandable, and safe decision support. Hypertension, diabetes, and dyslipidemia each have their own goals and recommendations, but in daily life they are not managed separately. Diet, exercise, or medication use about seeking care can affect several conditions at the same time. So self-management for multimorbidity is not simply the sum of several disease-specific plans. It is a process of coordinating several health problems together. For this reason, I designed to support combined the self-management and care-seeking decisions, not just disease by disease information. General purpose AI, such as ChatGPT, can communicate naturally and answer a wide range of questions very quickly, but this gives it clear potential to improve access to health information. However, for health questions, especially symptom or emergency questions, a fluent answer is not enough. The answer may also change depending on the wording or context of the question. Most importantly, in an emergency, a confident answer was more also need to a safe action. So, fluency and reliability are not same thing. I wanted to use the strength of the language model, but also ground the answer in selected evidence and add safety features for a specific target population. This is why I chose RAG. RAG stands for Retrieval Augmented Generation. It first retrieves information related to the user's question from a trusted knowledge base and then generated an answer using that information. I chose the RAG because I wanted to answer to start from evidence that I had selected from the clinical guidelines and public health sources. RAG also makes the source more traceable and allows the knowledge base to be updated without retraining the whole model. Yeah. But grounding alone is not enough. I consider three layers. First is the left-on grounding, and second is a communication. How that evidence is explained in a way that older adults can understand and use. Third is the safety, how the system gives urgent action first when warning signs are present. I believe these three layers needed to work together, and based on this idea, I set the study aims. The main aim was to develop and evaluate the chatbot mate to support symptom-based and self-management and health-related decisions for older adults. First, I developed the RAG-based chatbot. Second, I refined it through the expert and older adult evaluations. Third, I evaluated the final system for RAG performance and emergency referral safety. And I also conducted a comparison of response length and readability with general purpose AI models. The main question across the study was, can this system be grounded and understandable, usable, and safe? Now I will show the overall study process. The study has 6 stages. First, I built a evidence base from trusted sources and developed it RAG prototype. Then I conducted the expert evaluation and used the feedback to revise this system. Next, I older others tested the revised system. Their feedback was also used for further refinement. After these steps, I evaluate the RAG performance and comparison with general purpose AI models. I will first explain what was included in the knowledge base. To avoid relying on unrestricted web information, I built the knowledge base from trusted Korean and international sources, including clinical guidelines or public health information and emergency safe criteria. For public health information and patient education, I mainly use educational materials or public Q&A from public health agencies page. After pre-processing, the final knowledge base contained 3,271 text chunks. These were converted into embeddings and stored in a vector database. So made searches within a reviewed this evidence base rather than the open web. The evaluation questions were not randomly generated by a language model. They were developed by the reviewing KDCA health information, like public health agencies, and Q&A and real consultation questions. For expert and user evaluation, I used the 5 representative scenarios like diet and lifestyle or medication management and exercise and self-management and risk symptoms or healthcare use. Each scenario included 3 questions, giving a total of 50 questions for formative evaluation. And final RAG and safety evaluation, I expanded the set to 15 to 50 questions. Each question was classified by evaluation type, disease area, and whether emergency referral was needed. For each question, I prepared a reference answer and an emergency referral gold standard label based on the clinical guidelines or health evidence in the knowledge base. This allowed me evaluate retrieval generation and safety against the same reference standards. Good RAG performance means that the system can retrieve relevant evidence, but finding good evidence is not the same as deciding what the user should do right now. For example, the system may retrieve a good document about chest pain, but if the answer gives a long explanation first and the urgent action only at the end, that may still be unsafe. So, MATE included emergency warning signs and criteria for the emergency care. When warning signs were present, the prompt and guideline logic were designed to place urgent action before self-management advice. Now, I will briefly show how the system works technically. User can ask the question by text or voice. When the question is entered, the system creates a query embedding. The retriever and then searches the vector database and retrieves the 5 most relevant chunks based on semantic similarity. And the retrieved context and sources are sent to LLM model. The model then generates an answer using a predefined defined prompt. The prompt tells the model to avoid diagnosis and prescribing, use simple languages, give the measurement guidelines, show warning signs, like that. Yeah. And the system can provide answers in both Korean and English. In this way, evidence retrieval and safety prompting work together. This slide shows the actual N8N workflow. N8N is a node-based workflow automatic platform where different functions can be connected visualizes. On the left is the knowledge ingestion workflow. It loads the sources files, extracts and cleans the text, or splits it into chunks. On the right is the runtime chatbot workflow. When a user sends a message, the AI agent connects the language model and conversational memory and the super-base retrieval tool to generate an answer. Next, I will show how this technical structure appears to the user. Mate response design followed by five main principles. First is to show the next action early. Second is use short and simple sentences. Third is to clearly state that the system doesn't replace diagnosis or prescribing. Fourth is to make warning signs easy to see. And five is to allow users to ask for more details or more sources when they want them. This is the actual Mate interface used in the study. Next, I will show how Mate responds to our common questions. This example asks, if my blood pressure is normal, can I stop taking my blood pressure medication? Mate first gives a direct recommendation. Don't stop the medication on your own. Then it explains that a normal blood pressure may mean the medication is working well, and then talk with the clinician before making changes and keep monitoring blood pressure. The key point here is the response logic, direct recommendation, short explanation, and clinician consultation. However, the short answer may feel incomplete, or while a long answer may create too much information burden. One repeated concern from the expert review was the balance between enough information and too much information. So the default answer was kept short. If the user asks for more details, the system can provide additional explanation. The same approach was used for the source links. Instead of showing long links in every first answer, the user can ask for sources. This question asks, I have chest tightness and shortness of breath. Is it okay for rest at home? In this case, Mate doesn't start with a long explanation. It first says not to wait and tells the user to call 911 or seek emergency care immediately. More details and warning signs come after the urgent action. The key principle is urgent action first. In a high-risk situation, the correct next action is more important than a long explanation. Next, I will show what experts and older adults found during evaluation. The expert feedback could be grouped into four areas. First is the age-friendly design. Answers should be shorter and easier to read. Second is interaction and transparency. Sources should be clearer, conservation should continue across the terms, and the system's role should be easy to understand. Third is the symptoms and safety. Warning signs should be more specific, and the system should ask follow-up questions about symptom severity, durations, and related symptoms. Fourth is the clinical positioning. It should be clear who made it for, when it should be used, and how it differs from general purpose AI. The user evaluation was a pilot usability study with 9 adults aged 65 years and older who had multimorbidity. The mean age was 70.5 years. About two-thirds had not used generated AI or a chatbot in the previous months. And the mean e-health literacy, it means electronic or internet health literacy score was 24.3 of the 40. Participants used their own smartphones or tablets and completed relevant tasks. Importantly, I used a concurrent think aloud methods. This means that participants described what they were thinking while they entered the questions and moved through the interface. This helps us see where they stopped or what they couldn't find and what was difficult to understand. The main SUS, it means system usability scale, means is 67.2 out of 100. In the post-use ratings, participants generally gave high scores for answer understandability, relevance, and support for symptom and care-seeking decisions. However, this ease of use was lower at 3.3 out of 5. This was an important finding. Participants linked and understand the information, but the overall experience of using the system was not as strong. This difference between health information quality and interaction usability became even clearer in the think aloud observation. In the Think Aloud sessions, participants liked the fast access to health information, concrete copying guidelines, or understandable disease information, and the option to ask questions by voice. But there were also clear interaction problems. Some participants couldn't easily find the input field or microphone icon. Some needed the verbal prompting, and a few texts required direct help by their caregiver. Small text, low contrast, and long answers was also reduced the readability. For emergency questions, more participants understood the main actions such as calling 911 or seeking emergency care. However, some had difficulty explaining the detailed emergency guidelines in their own words. So the rating scales looked positive, but direct observation showed important barriers to independent use and accessibility. This led to one of the most important findings in the study. One key human-centered finding was that understanding the information and being able to use the system were not the same thing. The mean rating for answer understandability was 4.4 out of 5, so most participants could understand the health information itself, but operational accessibility was different. Some participants had difficulty finding the input field, use buttons or voice functions, or completing text with help. This suggests that content comprehensibility and operational accessibility should be evaluated separately in digital health systems for older adults. Even a very good AI answers has little value if the user cannot enter the questions or find the needed function. At the same time, an easy interface is not enough if the information is too difficult to understand or unsafe. So both information quality and interaction accessibility need to be designed and evaluated together. This observation also guided another round of system refinement. The final performance evaluation used the 50 question I described earlier. I used four RAGAS metrics to evaluate the RH system. RAGAS is an AI-assisted evaluation framework for RH systems. It uses language models to assess the quality of retrieval and generated answers. Context precision was 0.98, showing that the retrieved chunks were highly relevant. Context recall suggesting that some needed information was not always re- fully retrieval. Mm. Fully retrieved. Faithfulness was and answer relevance was showing room for improvement in how the retrieved evidence was used in the final answer. BERT BART score F1 was the 0.89, indicating high semantic similarity with the reference answers. Overall, retrieval precision was very strong, while retrieval completeness and the generation stage still had room for improvement. However, for this study, emergency referral or safety was even more important than the average technical scores. For safety evaluation, I compared MATE's referral decision with the emergency referral golden standard. There were 15 emergency cases in the 50-question test set. MATE recommended emergency care for all or the 15 cases. So the emergency referral sensibility was a 1.0 and the under triage rate was 0. Overall accuracy was 0.98. In this initial evaluation, my main safety priority was to avoid missing an emergency case. However, there was one false positive emergency referral, so safety should not mean simply referring every uncertain case to emergency care. The overtriage case didn't include a clear emergency warning sign. The symptoms were more uncertain and the system responded conservatively. This suggests that the safety-oriented prompting may help reduce missed emergencies, but it can also cause unnecessary clinical visiting, or if every unclear symptom is treated as an emergency. In future versions, the system should not always classify risk from only one question. It should ask follow-up questions about symptom severity or durations or progression or related warning signs and current blood pressure or glucose values. So safety is not only about avoiding underthriving, it should also support its escalation that is proportional to the actual level of risk. This will be important if made develop from a one-turn answer system into a multi-step symptom clarification systems. And this was not benchmark of clinical performance. It was a just comparison of response length and readability using the same 50 questions. GPT had the shortest average responses followed by Mate, Gemini, and Claude. For grade level, Mate had the lowest score at 14.6. However, this does not mean that Mate was easy enough for older adults. The user evaluation still showed readability and accessibility problems. So response length and readability scores alone cannot tell us whether a system is truly usable. Finally, I will summarize what these findings shows and what they don't establish. This was an early study showing the potential of MATE as a purpose-built system for evidence-based health information and symptom-based self-management support for older adults with multimorbidity. The next steps are to improve the age-friendly interface and strengthen voice and the read aloud functions, and develop more structured symptom clarification. In the long term, clinicians and nursing experts should continue to review the knowledge base and the generated answers through a human in the loop process. Future studies should also examine long-term outcomes such as self-management behavior, healthcare use, and clinical usefulness. So I see the current result not as a final point of deployment, but as only evidence that helps guide to next steps of evaluation. To finish, I would like to with three main messages. I would like to close with 3 points. First is the evidence grounding is important because it connects generative AI to trusted sources, but grounding alone does not make symptom guidelines safe. Emergency support needs separate safety design. Second is the experts and older adults found different but complementary problems. Experts focus more on clinical safety, transparency, and role boundaries. Older adults, like usability tests, showed operational problems such as finding controls and using the system independently. Third is the understandable information and an accessible system are different design challenges. In health AI for older adults, content comprehensibility and operational accessibility need to be designed and evaluated together. Yeah. That's it. Thank you very much for listening. I welcome your questions and comments.